Tanya. It's saying meeting is now streaming live.
We're live now.
We're good to go, Mr. Chair.
Thank you, Dr. Harris. So I'd like to call the Grey Bruce Board of Health meeting to order. First item of business this morning, we better do roll call.
That's me. So we have Sue Patterson,
Present.
Brian O'Leary,
Present.
Ann Eady,
Present.
Chris Peabody,
Present.
Brian Milne,
Present.
Selwyn Hicks, Selwyn Hicks,
Present.
Al Barfoot,
Present.
Paul McQueen.
Present.
Okay.
All right, so we have quorum this
Morning, Aaron.
Morning.
Okay. Are there any amendments to the agenda this morning?
Mr. Chairman, I was wondering if partway through Dr. Ayer's presentation, or wherever we could ask a question regarding the chemistry part of one of the new vaccines that's being proposed, as a comment from him on it.
Sure. Feel free during the presentation, Al, when you feel it.
Okay.
Okay, any other amendments this morning?
Sorry, it's Aaron. Just the one media release that was sent out yesterday.
Okay. We'll put that as an addendum to call that 7.114.
I think it'll be 7.117.
7, okay, okay.
Oh, yes.
Okay. Are there any other amendments? Mover and seconder to move the amendments.
O'Leary.
Sue.
And Sue, is anyone opposed? Hearing none, the amendments to the agenda have carried. The approval of the agenda as presented with the amendments, the mover and seconder.
Edie.
And Millen, anyone opposed? Hearing none, I will consider that carried. Thank you. At this time, I'd ask anybody to disclose a pecuniary interest, either now if it rises down the agenda. Hearing none, I need a mover and seconder for the minutes from October 23rd and November 6th.
Edie.
Buck.
Ann and Buck, were there any errors, omissions, or discussions from those meetings? Hearing none. Anyone opposed? Okay, I will consider that carried. Thank you. Okay, presentations this morning. First one is the Grey Bruce Ontario Health Team Development. Alan Madden. I saw Alan online, so Alan, I'm going to turn it over to you. Welcome.
His slides going here.
I have a phone number trying to join. It doesn't show me who it is.
Who's
Here. Good morning. Can you hear me?
Yeah, I can hear you fine, Alan.
Yep, I can hear you, Alan.
Good morning. Can you hear me? Yes, sir.
Yeah, we can hear you. Sorry.
I can't hear you.
Can you hear us, Alan? Sorry. Can you hear us, Alan?
I don't think he can.
Good morning. Can you hear me?
Good morning, Al. Can you hear us? Would you be able to text him through the chat to maybe call through the phone?
Which Al is
I'm wondering, Dr. is
Good
Dennis?
morning. I don't know if you can hear me or not.
Yes. Can you hear
We
us,
can hear
Alan?
you.
Okay, Dr. Ara, I saw your thumbs up. Okay, I certainly can't hear. No, I can't hear you, Connie.
Connie, would you be able to type to him that he can proceed with the presentation? We can hear him.
Hi, Paul. Okay, I'm going to go ahead with the presentation, given that you guys can hear me. It'll be difficult for me to take any questions at the end, and I really wanted to condense the presentation so that I could take questions at the end and be able to respond to any questions and or concerns that council might have. First of all, I want to thank Dr. Ara and council for giving me some time, allowing me to spend some time with you this morning. We're under a very important task at this point in time, creating a Grey Bruce Ontario Health Team. I'm not going to go through the slide deck per se, but I will ask that Aaron move along to specific slides. I'm going to go through a prepared script instead, which will be a lot briefer and allow us more time at the end for questions. So let me start by saying that currently there are between 40 and 50 healthcare providers right now in Grey and Bruce. There are 3 hospital corporations that provide services from 11 different sites, 11 hospitals. There are 6 family health teams. There's 1 community health center. There's 1 CMHA. There's 1 Keystone and Family Services for children's mental health. Certainly Chapman House provides hospice. And there's 1 home and community care organization. There's Lynn Managed Home Care. Within the Lynn Managed Home Care envelope, there are service provider organizations that actually deliver home care and are contracted with the ministry to do that. And of course, there's Grey Bruce Public Health Unit. All of those individual entities receive a budget from the Ministry of Health to deliver specific services, and many are held accountable through something called an accountability agreement. In the future, the Grey Bruce will eventually be an integrated system of care, receiving 1 budget. So the Grey Bruce Ontario Health Team will receive 1 budget. They'll be held accountable through an integrated balanced scorecard, and it's referred to as a bundled care budget, and their responsibilities will be to deliver all care in an integrated manner across Grey and Bruce. If we go back in time, the readiness assessment was completed in the spring 2020. The complete application goes in on December 11th, 2020. Originally, it was September 18th, and the Ontario Health Team asked that we okay, sorry, I'm just got a text here, an email. I'm ready, Dr. Ara.
Okay, so I'm just going to...
We're initially going to submit the application on September 18th. That was deferred to... Can you hear me?
Yeah, so if we need to ask you a question, we can ask you from here.
Beautiful, beautiful. Can you guys hear me now okay? Okay. So originally the application was going to go in on September 18th. The committee decided to seek further community input into the cares and concerns that individuals of Grey and Bruce had. And as a result of that, it was deferred to December 11th. I will ask Aaron to go to slide number 5, please. So again, in July, we received confirmation that our readiness assessment had been reviewed. A full application was to be submitted by September 18th. Indeed, My responsibility was to write the application on behalf of the Ontario Health Team. The decision was made to defer the submission and allow more time for community engagement. The submission date is now December 11th. Any participating organizations will require board approval prior to that. Under the plans and goals of the Ontario Health Team, we were looking at a complete stakeholder engagement strategy over the next 5 weeks. Next slide, please. Responsibility rests with all of us, and responsibility was distributed across all health service organizations within Grey Bruce. The key stakeholders for us to engage with included the Grey Bruce Integrated Health Coalition, municipalities, and I volunteered to do 5 municipalities that fall within our boundaries, certainly physicians, patients, residents, clients, and caregivers, Indigenous communities, service provider organizations, and boards, which is not included on that slide. What we have in the application is we have something called our first-year population, target populations that we're going to provide services to. Our first-year priorities that were identified are frail seniors and mental health and addictions. And I'll give you an example of how fractured the system is today. I'm aware that the EMS has a frail senior strategy, the home and community support services have one, home care has one, the hospitals have one, and indeed the community health center has one. The reality is that none of us talk to each other, and we're all trying to do things haphazard, as opposed to doing things in an integrated manner that complements each other. So that's essentially what the Ontario Health Team goal is trying to achieve. So it's frail seniors, mental health, and addictions, and that was unanimous across the group in terms of what we were going to focus on in our first year. Once the application is complete, we will receive a site visit from the Ministry of Health. At that point in time, they will meet with us, engage with the planning committee, and just have a sense of how we're getting along, how we're cooperating with each other. And there are many examples of how institutions have cooperated across Grey and Bruce. One of them is the relationship that the community health center has with public health. Indeed, there's a dental office in our site in Markdale, a number of programs that we cooperate with public health on. And those kinds of cooperative gestures are what the Ministry of Health is looking for. So right now, the Ontario Health Team has a planning committee that is undertaking all of these responsibilities. The planning committee is comprised of about 18 members. I'll give you an example of who the planning committee members are. So there are physicians, hospital CEOs, the Community Health Center, Family Health Team, Community Mental Health Association, Keystone, Public Health, Chapman House, Respite, Patient, Family, and Caregiver Advisory Committee members, and indeed Southwest Lynn Home and Community Care. The Planning Committee recently hired a coordinator on behalf of the Planning Committee to undertake some administrative duties, including completion of the application. Could we go to slide number 18, please, Aaron? So if you consider what the Ontario Health Team in Grey Bruce is trying to achieve, there are a number of targets here that we've identified. Number one, we want to reduce the amount of time that is required to receive a home care visit. We want to reduce the number of patients with mental health and addictions that are showing up at our emergency departments. Some people would call that we want to be upstream in terms of the services we're offering to mental health and addictions patients. We want to reduce admissions to hospitals. We want to improve access to primary care. In other words, can you see your primary care provider the same day or the next day when required? We want to increase the percentage of hospital patients who see their primary care provider within 7 days of discharge. We want to reduce the alternate level of care rates to ensure people are cared for in the appropriate setting. An ALC patient is an individual that's sitting right now in a hospital bed that doesn't need to be there. And a large proportion of that is because they can't get the home services that they need in the home to be able to keep them safe at home. So some of the questions that we're asking ourselves is, as time starts to progress, is how are we going to go about changing the system to achieve some of these honorable goals? So I just, there's a question at the bottom that says, what steps are your board taking to improve the health, the performance and health of the system. Indeed, our board is very much engaged. We have been with the Public Health Board as well, and we continue to look forward to those engagements. And we're also concerned about making sure that the Ontario Health Team has a strategy to engage with public boards across the system on an ongoing basis. Next slide, please.
Next slide, please.
So some of the questions that we have for engagement, and we now have these answers back. There were a number of surveys that were undertaken. What does a successful OHT look like to you? How can we improve caregiver and the provider journey? How can we learn and improve from one another? What would you identify as potential barriers? What do you think are the biggest challenges patients, residents, and clients face in engaging with OHTs? A lot of this, a lot of the information that we're getting back talks about system navigation, about an individual being able to go to one place and receive questions with regards to the entire health system, as opposed to having to go to 5 different doors and receiving 5 different answers. And what complements that, of course, is having one patient record that would support that kind of endeavor. What support is needed for the OHT to learn and improve rapidly? How can we improve our health equity footprint? Health equity specifically talks to vulnerable populations, which I know that public health is very concerned about. What digital health solutions would you recommend for improving the health system? I'll give you an example of number 8 and how integrated services can thrive under an OHT. Recently, the Community Health Center established a strategic partnership with Chapman House. Chapman House is a 24/7 operation that has health service professionals providing services from that location, and they never had something called an electronic patient record. We agreed to share our patient record with them, so they will have access to our 9,000 patients. Their specialists will be able to support our physicians and nurse practitioners delivering palliative care in the home directly, and also in response, when we close our doors at 8 o'clock at night or on a Sunday, when our phone rings, it'll actually ring in Chapman House, and a registered nurse will pick up the phone and say, Community Health Center, how can I help you? So essentially what we're doing by partnering is we're creating 24/7 access to primary care. Those are the kinds of innovative things that the ministry is looking for under the Ontario Health Team banner. Next slide, please. So the next step for boards, certainly provide feedback. I know that Jane has been involved with your board chair. Executive directors and CEOs will be asked to solicit feedback from their boards. Membership sign off, the full application will be circulated to all of the organizations, and indeed it has been this week. Recognize the submission of the full application is just the start, and each organization should ask itself, how are we going to work with our partners to enhance the people that we serve? So I'm going to stop there, and I'm quite prepared to take any questions and give you an update on where I think things are at right now from an OHT perspective.
Okay, so we will try to get some questions through to Alan. Does anyone have a question or a comment at this time?
It's Ann, Edie.
Go ahead, Ann.
And so I've been trying to understand what your overall picture is for the Great Health Unit under this new concept of Ontario Health Teams. Do you have any top level view, or are you just waiting? Does that happen down the road? But I'd kind of like your input. You've been part of this probably right from the very beginning, and has our role as Grey Bruce Health Unit been discussed, or is that come later?
So I think, thank you very much for the question. It's an excellent question. And I think that, oh, I've just lost you, Ian.
We hear you.
Can you hear me? You can still hear me okay. So you're gonna have to call me back because I can't hear further questions. So it's an excellent question. What I would suggest is that the Ontario Health Team is responsible for looking after all entities and all services within Grey and Bruce. And I'll give you an example. If I can call you Ann, I'll give you an example, Ann. An example is that public health is very, very much engaged with vulnerable populations and delivering services that are considered to be proactive as opposed to reactive. I'm very concerned that the evidence within the application does not support some of those services as much as it should. And so it's a health promotion approach that public health offers, and that needs to be embedded in the services that we offer, and it needs to continue as a vital service as part of what the OHT is delivering. And indeed, a large part of what we do as a community health center is deliver those kinds of services as well. And we do it hand in glove with public health. Public health needs to have a very strong position at the OHT table, a very strong position that is respected and guided, and is being captained by Dr. Ara. And I think that in terms of the raison d'etre, or the reason that public health exists, that needs to be expanded and broadened, not narrowed under a new OHT banner. So it's going to be very important that we don't get sidetracked with agendas, either that focus on acute care or whatever. And indeed, we had presented in the September 18th application an OHT that was led by primary care, which would fit hand in glove with the services that public health offers. So I'll leave it at that, Anne, and I hope to have answered your question.
Thank you. No, that was very good.
And if I may add, through you, Mr. Chair, Dr. Ares here, I totally echo every word Alan mentioned there of the importance of the alignment and coordination between the different sectors, including public health at that table.
I guess if I could, Mr. Chair, we cannot have a system that is driven by one silo. There are 5 silos of healthcare. There is public health, acute care, primary care, there is long-term care, and there is home care. And we can't have a system that is driven by one silo. It has to be driven by the needs of the population within a specific geography. And public health plays a vital role in delivering services and meeting those needs. Thank you. Next question. Good question. Thank you, Brian. Maturity, will the OHT have a board of governors who will receive? That is the vision. My concern is that the language within the application has not been strong enough to guide that. So there has been discussions at the OHT table, and let me tell you where the challenge is. The challenge is that some of the major players at the table, and I'll be candid, the family health teams, they don't have community boards. They have physician-led boards. So the challenge is how do you set up a structure that engages physicians as well as the community who represent the patient? So the vision is that we would have a community board, Brian, and that community board would also be comprised of physicians, patients, families, and caregivers, as well as community members and municipal leaders, I would suggest as well.
Other
Next question,
questions
please.
or comments?
Sorry, am I? No, I just had one more question. So you talked about the 5 silos. When you look at the 5 silos, it's just from my experience that the healthcare in the community, you know, where we used to have pretty good availability of healthcare workers going into homes. And as I've watched over the years, then that they didn't want them in homes. They wanted to go to a center in the community. And you had some very sick people that had been sent home from the hospital, then having to go to these centers. And so is the vision to get back to that model where patients that are pretty frail or sick will still have care in their homes again? Some of them, it was almost impossible to get to those centers for them. That's so a kind of view of the 5 silos, maybe that has become the weakest link just as a community person, but I'm not a healthcare expert, but I just am hoping that that silo isn't neglected as well.
I agree, Anne. And if you look at the philosophy behind an integrated balanced scorecard, so our institution, the Community Health Center, has a balanced scorecard, and my board, my behavior is driven by my board. I report back to my board on all of the indicators within the balanced scorecard on a monthly basis. They hold me accountable for making sure that I achieve certain thresholds and certain targets. An integrated balanced scorecard will bring the 5 silos together and have one balanced scorecard for the system. So that the vision is that all of the individual silos will be driven by the same measurements and the same performance indicators. And all of our individual boards will hold members of the OHT accountable for achieving those individual balanced scorecards. So we'll have 2 responsibilities. We'll have an OHT balanced scorecard that we're 50% responsible for, and we'll have a CHC balanced scorecard that I'm also 50% responsible for. I hope that helps, Anne. There's a couple of other questions here. I saw one from, so would any possible mergers in health units within the province have an impact on the Grey Bruce Ontario health team? It's a good question. And indeed, would, in a future state, would the Grey Bruce Ontario health team also include Huron-Perth? I don't know. I think that's a little bit of crystal ball stuff. Dr. Ara would probably be able to answer that better than I would. I think that there are going to be system partners that we have that don't reside within Grey Bruce. So we're always going to have responsibility to the specialist services that exist in London, in Toronto, in Newmarket, and in other centers as well, the tertiary care. So we will always have a relationship with those centers. And I would suspect it's a very good question. I'm probably going to defer to Dr. Ara to respond to that one. Where will the accountability for the funds lie? Good question, Brian. So right now, we're looking at one back office. There are sort of 2 schools of thought. One was that we would create a new entity called the Grey Bruce Ontario Health Team, and the funds would reside with them. The other is that we would use an existing entity and the funds would reside with them. The appetite from the hospitals is not to create a new entity, but to allow the funds to reside with the largest corporate entity, which would be Grey Bruce Health Service. From Mr. Saunders, I see silos within the hospital itself and not, yeah, as do I. And so that's about leadership, I think. And I would suggest very strongly that that will be the responsibility of the new leaders within the system to break down those silos. If I could give you an example, I sat on the Premier's Council to eliminate Hawley medicine. And when I met with Ruben Devlin, he said, okay, go ahead and talk. And I said, well, can I tell you a story? And I told him the story about the first time that I came to Markdale. And the first time that I came to Markdale, there were 5 mental health agencies located along the main street. There was Hope Grey Bruce, there was CMHA, there was Keystone, there was the hospital, and there was us. And none of us talked to each other. And the vision that we had that back in that day was to try and bring them all together. So at least improved communication between the group, because our patients are shared and patients don't care. They don't want to have to go to 5 different doors to get answers. So we created a mini health hub in Markdale. And I think, and public health is part of that, and it seems to be working very well. If you can expand on that vision and bring all of the players, all 5 of the silos together, imagine the services that you could offer when the first question you ask when somebody comes in through the door is, how can I help you today? And you have perfect system navigation for all of the 5 different silos at your back. So that's sort of the vision that we have at this point in time. We hear you. That's all I've got for questions right now. Are there any other questions that people have? I'm probably at my 20 minutes. Will the OHT pay physicians? Good question. So Right now, the legislation doesn't exist for the physicians to be paid by the OHT. The only model where physicians are paid by the OHT is the public health model and the CHC model. My physicians are actually employees, and we don't bill OHIP. So my physicians have an agreement with me, with our institution, that says, I'm going to pay you this much money and you're going to do X, Y, and Z. So they're held accountable by the same accountability agreement that I have. And I think that in the future, there has been some discussion about limiting the number of different pay models that exist. So family health teams really are just a pay model for how you can fund and pay family doctors that exist within a specific organization. So I would strongly suggest that in the future, there may be a limited number of different pay models that would be held accountable by their individual OHTs. Good question. Pleasure, Brian.
Okay, is there any other questions?
Any other questions at all?
Okay, Dr. Era, I'm not hearing anymore. So for a path forward, what kind of direction are you looking for or thinking?
Really difficult to hear. Dr. Ara, can you repeat the question?
Sorry, Mitch, if you can repeat the question.
So moving forward, what direction are you looking for, Dr. Era, from the board, or your thoughts moving forward?
Breaking up quite a bit. I'm really sorry.
No worries, Alan. The question is to me. The question is to me.
Okay.
In general, this presentation is for awareness. During the pandemic, we've been focusing on COVID and the planning for the Grey Bruce Ontario Health Team has been undergoing. Our directors were attending those meetings. However, I do believe certain changes happened from last year. Last year, there was a certain direction and a plan in place. In the recent few months, there has been certain changes. So I do believe Alan's presentation is very timely, just to bring us up to speed with things. There is no specific recommendation from me at this point, other than just being at that table and being active in ensuring one point, as the board directed us to communicate with other boards about the importance of governance establishment before the submission of the application, and ensuring that the community is represented in that governance model, whether it is elected officials or citizens or board members from different boards in Grey Bruce, participating in two things: the planning for the Grey Bruce Ontario Health Team, and equally important, or maybe more important, to be in the governing body for the Grey Bruce Ontario Health Team down the road. And I wonder, Alan, if you have any comments on what I said.
The relationship that we have with public health is fantastic, and I really appreciate all of the people who work there and the great work that you're doing during this extremely difficult time. There are a number of different agendas at play. I'm going to be honest with you, and I don't know where things are going to fall, where things are going to lie. It's I've never been known, and Paul McQueen has known me for a long time. I've never been known, Paul, to be a wallflower. You don't get things done by being quiet and sitting at a meeting and not saying anything. So that doesn't always put me in the best of a position with a group of people who don't want to change. But there needs to be a number of leaders at the table who are like-minded, who want to change the system for the sake of the patients and not for the sake of egos. And I think that we've got a core group of people who have those concerns. I'm optimistic that over a period of time, goodness will prevail, and we will be able to work through some of the personnel issues that we currently have and land in a place that's going to be better for all patients. I'll leave it at that. And I just for the sake of the people who, and thank you again for allowing me to spend 20 minutes with you this morning. But Dr. Ara and I have weekly calls, and we are in contact with each other all the time, every day. We're texting, we're talking, and there are a number of other institutions who are engaged in that as well. So we're communicating on a regular basis, I would be happy to continue to keep this board involved and be able to respond to any questions that you might have. Thank you, Paul, for your kind words. Dr. Arra, I look forward to our next call, and I want to thank you for your leadership and for the great work that public health is doing in managing this crisis. Thank you.
Okay.
Thank you, Alan, for your kind remarks. Through you, Mr. Chair.
Okay, thank you very much. Good presentation. Okay, so we will move on to the next delegation. And this morning we have Dana Leach, who's going to present the COVID-19 emergency response and long-term care report. So Dana, the floor is yours. Thank you.
Good morning. I'm just finding to share my screen here. And give me a moment.
We see your screen, Dana, now.
Okay, do you see it with the slide show?
Yes.
Okay, super. Well, good morning, and thank you very much for having me come and talk to you a little bit about the COVID response and long-term care, retirement homes. We've also added childcare because that's an area where I think the similar structures and public health response have been supportive. So I'm going to give you a bit of an overview. Many of you know that I'm the infectious disease manager, and it's going to be kind of difficult to explain all the things that we've been doing since, well, March 13th comes to mind as being sort of where we activated our response in full depth. But of course, many of you have seen us with our delegation back in January and February to your county councils, but we'll give a bit of an overview. And to start, I just want to describe what I hope to achieve through this meeting. I want to just give you an overview of the role of public health with prevention and control of outbreaks in long-term care, retirement homes, and childcare, and talk to you about the partnerships that we've had with long-term care, retirement homes, and childcare. Specifically, just to give you an overview about what they look like prior to COVID, and also what we're doing presently with COVID, and just a few remarks at the end about where we are going forward. So in terms of where our role of public health, we act under the authority of the Health Protection and Promotion Act in accordance with the Ontario Public Health Standards, requirements for programs, services, and accountabilities, including the protocols. And in specific to infectious disease, we have a number of areas, but I'm just talking about the two and working with long-term care homes, retirement, and childcare. But we are required to provide public health management of cases, contacts, and outbreaks to minimize the public health risk. We are also required to have qualified public health personnel available 24/7 to provide guidance and assistance to support institutions with the prevention and control of outbreaks in long-term care, retirement homes, and childcare. And this is one of our 21 requirements in public health. And these were the documents that guided us pre-COVID, in particular with long-term care, recommendation for control of GI outbreaks, as well as a recommendation for control of respiratory outbreaks. And just to provide a bit of context about what that looks like, we have 19 long-term care homes in Grey Bruce. We have 24 retirement homes. We work with 11 hospitals. We have, in terms of Bruce County childcare, we have 59 licensed centers and licensed home centers. This doesn't include the informal childcare. And in Grey County, we have 63 licensed centers and licensed homes. So when you look at the numbers, that's certainly a lot of partners that we work with. And just in, again, giving a bit of COVID context, the childcare centers, the licensed childcare centers were closed March 16th. They were able to reopen with some restrictions in June and then fully reopen September 1st at regular capacity. Now, some chose not to open, but it certainly is giving you well over 100 childcare facilities that we are working with formally. What we did before COVID, working with these.
Sorry, Dana, should we be advancing the slides for you? They're not advancing on our side.
Oh, yes, please. They're advancing on my side. I'm on slide 6.
Sorry, I can't advance the slides unless so
Yeah,
you'll
okay,
have
so,
to click on the slide number.
okay. You're not seeing them. Forgive me. Do you want me to stop sharing, Erin, and then you just go to the?
Sure. Yeah, we can do it that way.
Okay.
Okay.
Forgive me. Thanks, Dr. Era. Yeah.
Just give me 1 sec, Dana.
Okay, thank you. Thank you, Erin. Well, they were certainly moving on my end. And I think Erin will be able to share the slides for you for the group. You let me know when you've got it, Erin.
Sorry.
That's okay.
Is that the right one, Dana?
I think it is. Thank you. Okay, so I just catching up again. We'll give you a copy of those slides, and my apologies. This Zoom technology, although we've been on it a lot, we're still finding a few things as we go along. So in terms of the public health interventions before COVID, our team performed food and environmental inspections, including IPAC practice support, which is infection prevention and control. We coordinated with long-term care and retirement homes to support testing at the public health lab, including the provision and distribution of specimen kits. We promoted and supported influenza vaccination for staff and residents. And during the respiratory or gastrointestinal outbreaks of your typical respiratory season, we provided daily support and representation on the outbreak management team for facilities, as well as providing disease-specific information to the homes. And in terms of our work too, we collect data, analyze outbreaks, report to the Ministry of Health and Long-Term Care on institutional outbreaks, and provide recommendations so we support the prevention of future outbreaks. Next slide, please. And sort of more hands-on intervention that we have, annual in-service education on infectious diseases for our partners with IPAC practices and outbreak management. We provide resources and tools to help them through outbreak management and prevention, quarterly newsletters on hot topics to ensure that we are reducing transmission in the facilities. We also attend their medical advisory committee, their physicians advisory committees at long-term care, and we attended childcare meetings for both Bruce and Grey County Children's Services. Next slide, please. And then COVID arrived. So we had some practices that we completed with these facilities, and then, as I said, COVID arrived. And next slide. And we enhanced all of the practices for which we had with these homes and facilities. We enhanced surveillance, we enhanced our communication, education, and support of the homes and childcare operators. We provided public health guidance on the evolving policies and procedures that were being put in place, as well as enhanced IPAC practices specific to COVID IPAC. And then outbreak prevention and management certainly became key for our facilities. Next slide. With enhanced surveillance in the long-term care, we worked with homes to ensure they had active screening at every one of their doors, making sure everyone coming into the facility was actively screened, monitoring residents at least twice a day for any change in signs or symptoms, and testing for residents and staff. There was certainly a lower threshold of testing for COVID. Even one symptom tested the home, and then we sent those swabs and arranged a 7-day-a-week courier system with line-list review every day. We also did similar enhanced surveillance with childcare operators and continue to do so with daily absence reports. And we have thresholds for which we follow up with homes to assess the absenteeism rates and illness that we've identified in each one of those homes. Those are happening daily. Next slide. We enhanced our communication. We're doing regular Zoom meetings since March 13th with long-term care. We implemented universal masking March 13th, long before any other jurisdiction. We created a special 4,000 extension line for long-term care, EMS, retirement home, police and fire, so they could have rapid access to our infectious disease team. We have created website-specific COVID info. We did weekly communication with our long-term care. We supported communications to family and staff, and both Dr. Era and Dr. Lee attended some of these sessions. We communicated joint press releases, our ongoing Zoom education and training, and we've been on site for those who need a little bit more attention during these outbreaks, with the same or similar enhanced communication, education support with childcare operators. We're supporting communication to families. We're doing Zoom education, and we've been to a number of homes as well to support them with their IPAC practices on site. And we helped by distributing some PPE provided by our generous community supporters, including Bruce Power and Chapman's. Next one. And then we had the public health guidance on the evolving policies and procedures, and it constantly was changing as we learned more and as we enhanced more going forward. And so we supported long-term care and retirement homes in interpreting and these guidance documents and their implication for their facility. Next slide. And we also shared new guidance and new knowledge that we had through our partners at Public Health Ontario with a COVID infection prevention and control checklist, and worked through every long-term care and retirement home through this checklist, and enhanced all of those prevention and management as we learned more about COVID. Next slide. And then the guidance documents came as the reopening for childcare, and we supported our childcare operators with Bruce and Grey County, CMSMs, and then their operators. We brought them online once things were ready to be opened up, and worked through those guidance documents. Next slide. And we provided the tools, and then the outbreak management. And we did, we certainly had some homes in outbreak, and we worked through stringently these outbreak checklists, step by step, to support these homes that they've gone through, and those who experienced an outbreak. Next slide. And that, as we know, and this was back in April, at that time we had 3 long-term care homes battling COVID outbreaks, and knowing that it's either one staff or one resident with a positive COVID. But we also worked with Dr. Era to ensure we were getting true positives, and work with our homes. But definitely we did experience, and presently we're experiencing one of our homes in a COVID outbreak, but we're early identification, early mitigation, and early IPAC practices to support positive outcomes. Next slide. And that our outbreaks are posted, full transparency, and also awareness, so people know what we need to do when we are in an outbreak. That's on our website. Next slide. And we know we've learned from experience and had very successful outcomes. And there's a great partnership in our community with long-term care retirement homes, and the partnership with public health to learn and conquer, as Mapleview did these COVID outbreaks. Next slide. And so going forward, what are we doing with our partners? We're continuing to ensure that they're screening staff and visitors upon entry. And as we've gone into the new framework of green, yellow, orange, red, and lockdown, what this means for these homes and how we can support them going forward. Ongoing monitoring and surveillance. And Dr. Era and I are working, I think it's next Monday, we're meeting to talk about rapid testing, so we can have these on-site tools to support early identification, and we can get a better handle on what's coming into the facilities. We're doing ongoing IPAC assessments, addressing and strengthening IPAC practices, and we continue to build on the strong partnerships of Grey and Bruce Partners, which we know are really strong. The long-term care and retirement home and childcare staff have demonstrated their commitment to providing the safest care possible, and for that, I think we are really privileged in this community. And I just want to say I'm privileged as the ID manager to work with such an incredible, dedicated public health team that are working 7 days a week with our partners. They know us, they call us, and we're committed to ensuring we have the best outcomes possible. And what else is going forward? Soon a vaccine, and I'm hoping we'll have a different conversation next time I meet.
Well, thank you very much, Dana. And I can't thank you enough for all you're doing for us right now. I can't imagine But thank you, and thank you to your team as well. Please pass on those regards. So I will open it up for some questions or comments from the board.
Thank you, Chair. I will certainly pass that on.
Mr. Chair, it's Brian O'Leary. If I could, I just wanted to comment. Dana, thanks so much for sharing this. The amount of information, showing the amount of responsibility under you is amazing, and I thank you for what you do. Thanks so much.
Well, thank you. And we certainly don't do it alone. We've got some guidance and support, we're talking daily at our ACG meeting about what we've got going on. So thank you.
And Edie.
Mayor.
I echo the comments about your dedication and your help to the municipality of Kincardine. It's great to have you on our emergency control group. And of course, Dr. Era has been very helpful as well, and all the staff. I think we had, I know you've been having busy times, but you still managed to find someone, if it's not yourself, to send to our emergency control group. So I just did want to tell you, I was on the CNSC hearings this week. I was trained, I had special training on how to take control of my PowerPoint. And I was looking forward to it, but the computer I was using at the office somehow caved just when I was supposed to do that. So I had learned that thing that you have to click on the slide. That so
I should have chatted with you ahead of time, Mayor.
But anyway, my question is, so how, as you know, the County of Bruce has the 2 long-term care homes. So how will this classification of colors affect the long-term care homes, or is it kind of treated differently?
Yeah, the Ministry of Long-Term Care has sent out some guidance documents specific to those facilities and what that means on the various color. It impacts on their staff surveillance. It also impacts on the visiting and the visiting conditions. And so, and whether they're in outbreak or not in outbreak. So there are some conditions that the Ministry of Long-Term Care has set out for these facilities, along with the directives from our Emergency Operations Center, the Ministry of Health. So there, and it is evolving, but it's clearly focused on staff surveillance, testing, and visitors.
Thank you.
I have a question, Mr. Chair.
Yes, sir, Mr. Millen.
Thank you. Good morning, Dana.
Good morning.
There's been a lot of chatter in the media regarding privately run long-term care versus publicly run. Through what you're seeing locally, do those observations bear out that there is a differing approach to the pandemic, public versus private?
I think you bring up a good question. I think it really depends. There are a number of mitigating factors in terms of how successful people are. I think it relates to what their staffing is involved, whether their IPAC practices, whether their PPE. I think locally, we have a great deal of partnership where we meet weekly and we do some mutual problem solving. And those that may not have the resources and tools in terms of policy development that they're sharing with each other. I do certainly recognize that the communication can be a challenge for those that are privately run in some ways, but we reach out to each and every one to the point where we've made, and we were making weekly phone calls. If we didn't see somebody on a Zoom, we were following up with them. We also have been really fortunate to have received PPE. So some of the private homes that didn't have access to PPE, or there might have been some distribution challenges or even accessing supply because they weren't with a bigger corporation, we have been able to do that with our partners and working with our logistics here internally. We ensured that every home had some access to PPE. I think that has been a huge difference in other jurisdictions.
Thank you, Dana. I appreciate that.
If I may, Mr. Chair, Thank you, Dana, for that answer. I echo everything you said there. In general, the stats from Canada in general shows that privately run organizations might provide less care or less service comparing it to publicly funded. Locally, we really cannot see the difference just because we're, as Dana said, we're working with everybody and there are multiple partners, whether it's if there is lack of PPEs for some, it is mitigated before it becomes an issue. So having everybody meeting that high level standard that does not allow us to compare from that point of view locally.
Okay, other questions or comments?
Mr. Chair, it's Sue. I would just like to ask Dana or even Dr. Era, do you see, can you look in your crystal ball, even when we have a vaccine, will all of these health protocols continue, or we won't know until we see the results of the vaccine?
So in general, if let's say the scenario where everybody in long-term care is vaccinated and the efficacy, as we know for the vaccine, is around 95, these enhanced measures to respond to COVID will not be there. However, all the measures that need to be there for other diseases, whether it's meningitis or influenza, would still be there, and in general will go back to normal after the vaccine is given to most people in these facilities, and I see no reason why it wouldn't be given to all people.
So, and if I may, Mr. Chair, so then that raises the question, what about the people that won't take the vaccine?
If we reach 70% of the public, and now I'm talking about the public, not the long-term care. If we reach the herd immunity 70%, that means the virus is not going to be circulating easily. These measures would still be necessary for people who didn't take the vaccine because they might acquire it. In long-term care, specifically, I would envision the scenario where usually there is more acceptance from residents to take the vaccine. There is almost close to 100% compliance. I would say, I would predict my own bias here, and that would be sufficient to protect the very few people who wouldn't.
Thank you.
Okay, other questions or comments?
Mr. Chair, it's Al. Just like a comment from Deanna and Dr. Era, just as a follow-up from Mr. Milne's question. From a ministry standpoint, they treat both publicly and privately run facilities, though with exactly the same supervision and inspectors that go into those homes. And I think that's a point that needs to be confirmed, where some people are of the opinion that there's two different sets of rules. But I think from the ministry standpoint, there's one set of rules for both of those style homes. And I just would like to get a comment from both of them.
Certainly, I can comment that if you are a licensed long-term care home, you are required to follow the same licensing requirements. There is the Long-Term Care Home Act. There's also the Long-Term Home Regulation, and you must follow all of those regulations. If people are not following those regulations, they're inspected by the Ministry of Long-Term Care Home Inspectors, and they certainly can have some citations imposed upon them with some impact to their licensing. And Dr. Era and I are meeting with the director of them in our region. We've already met with our regional manager for the Ministry of Long-Term Care to ensure we're communicating and keeping things open. But yes, they absolutely, you're right, Mr. Barfoot, they absolutely have to follow the same requirements in that Long-Term Care Home Act.
For you, Mr. Chair, correct, it's the same requirement. In general, if you look at the publicly run healthcare system or privately run, the evidence is very clear that privately provides less quality of service. During the pandemic specifically, the review from Public Health Agency of Canada for across the country comparison between long-term care, private versus public, has been consistent with this evidence. But back to your question, it is the same standard.
Mitch, if I could comment on that.
Thanks, Matthias.
And Mitch, it would be interesting to take a look at the data. I don't think it's up to the health unit, but I think both in Bruce and Gray, we do have a suspicion that the municipal homes get more attention on the inspection side than the private. So certainly would be interesting for somebody to do a study. Municipal homes make up 18% of the homes, so it would be interesting to see how much of the inspection work they get.
Any comment, Dr.
Era? Certainly, through you, Mr. Chair. My observation during the emergency, every partner, every long-term care, whether private or public, has been meeting the expectations, and as always during the pandemic, exceeding the expectations. So, like you rightly said, Mayor, it's not public health mandate to compare these inspections. However, I suspect if that comparison happened, it would show that that everybody has been doing over and beyond. Inspection from the ministry is something that I can't comment on, whether they do more inspection on public versus private. It's worth looking into, definitely. I wonder if is the question just a question and comment, or potential direction for us to
No, not direction, because I don't think it's our purview, but it is, since we between us have 5 nursing homes, it's an anecdotal observation.
If I may, could I make a comment?
Yep, go ahead, Dana.
So the Ministry of Long-Term Care they do inspections in 3 ways: complaints based on reporting of critical incidents, and also based on what they have an action line or proactive inspections, just concerns on the radar. And all of their reports are posted. That's something that anyone can have access to. So I just share that. And perhaps it's a matter of disclosure of critical incidents, which are required per the Long-Term Care Home Act and the regulation. So it may mean that county-run homes report their critical incidents. I don't know, but that's in terms of the 3 ways for which an inspector would come in. But if you are interested, you can certainly look at anything. It is publicly available based on the reports in every home in Grey Bruce.
Okay, thank you, Dana. Other questions or comments for Dana?
Mr. Chair, it's Brian. More so from what Dr. Ara was talking about with the people refusing a vaccine. Dr. Ara, if you need 70%, if that would be sufficient, what's your best guess in terms of percentage of the people that will not take the vaccine? Would it be closer to like 10%?
So the stats in general, the people who would completely refuse the vaccine, anti-vaxxers, usually the term used, is very minimal. It's 1 or 2% or less, depending on the area. There are people who would say, I am not inclined to take the vaccine. And the last number I heard from Public Health Ontario about 2 weeks ago was around 30% who would say, I'm reluctant. The older the individual is, the higher the chances to accept the vaccine. So in our area specifically, I would suspect it's less than 30%. The number from Public Health Ontario was provincial. More or less, there is one specific point there that this number actually changes based on the information that's provided and the amount of communication that goes out to the public, so they would have the information at hand to make their decision. So in short, I suspect it's around maybe anecdotally from my assessment is around 20% who might be hesitant to take the vaccine. However, that's a number that can change with our communication that we plan to put out.
Okay, thank you.
Other comments? Okay, hearing none. Thank you, Dana, again for all you do.
Well, thank you, Chair. And sorry about the slides, everyone.
That's okay. Okay, moving on to correspondence and news releases. You've seen the news releases and correspondence. Is there any discussions or comments on any of those releases? Dr. Ayer, was there any that you wanted to highlight?
Only, thank you, Mr. Chair, the school incidents and the success in the response we've been sending immediately media release to let the public know about any incidents in the school, and one after the clearance of the incident. So it has been a success there to maintain that high level of protection.
Mitch, just wanted to thank Dr. Ayer for item 7.16, the water well testing. There's a little gap there caused by COVID with rural well testing in the center of Grey Bruce, so that'll serve residents in West Grey and Southern Bruce County, having that service restored to our area. So thank you, Dr. Ayer.
Through you, Mr. Chair, the thanks go to you, Mayor. You identified and your team identified the local health need, and we only have been following your lead on that. So thank you.
Okay,
Mr. Chair, just
yes,
one. Thank you. Just I wanted to comment and thank Dr. Ayer for his engagement with the community, the Mennonite community rather, here in Southgate. It's been much appreciated. I've talked to a couple of the community here that are involved, and they're very, very much appreciative of Dr. Ayer's efforts to help them and guide them through a difficult time. So thank you, Dr. Ayer.
Thank you.
Okay, any other comments? Okay, do I have a mover and seconder to receive the correspondence and news releases?
O'Leary.
O'Leary.
Peabody.
Any further discussions? Hearing none. Anyone opposed? Hearing none, I will consider that carried. Thank you. Okay, moving on to the Medical Officer of Health update. Dr. Ayer.
Thank you, Mr. Chair. So if I can ask Aaron to share a screen about the examples of surveillance tools in Grey Bruce Health Unit. And to start there with that screen is just one set of tools that we use for surveillance. And if I may, Mr. Chair, just provide a quick update about the situation in Grey Bruce and link it to the screen surveillance tools as well. So as we all know by now, the numbers have been increasing in Grey Bruce. Our health unit moved from the green to the yellow, and that's the appropriate decision happened in consultation with the Chief Medical Officer of Health. Our indicators last week were 50% in the green, 50% in the yellow. However, the trend is moving to yellow. So my recommendation, and it was a mutual decision to move to the yellow. This week, we continue, I would say, going forward to be in the yellow with monitoring of the situation. There is one significant of critical significance number, which is the high risk contact. So whenever we have 10 cases, they're generating around 60 to 100 close contacts. This number has increased comparing to previous stages from the pandemic in March and April. For each case, we used to find 2 to 3 household high risk. Now, this number is increased. And practically, this number is the number of people we interact with outside of our household with less vigilance that we should have. The underlying principle to this number is fatigue from COVID, and the appropriate response would be to increase the communication to provide the public with information and increase their awareness and concern. To my delight, Bruce Power has invested $1 million in a campaign that's geared exactly to this goal, and in communication with Bruce Power and where to emphasize and how much to increase the communication. We're seeing in general, it will take 2 weeks from now to see the numbers changing based on that effect. However, we see anecdotally that there has been change in attitude, and that's the first step in changing behavior. Usually communication leads to change in attitude, then attitude changes behavior, the behavior would translate in numbers down the road. So I believe we are on the right track to continue to have control over the outbreak. There are a couple points there before I refer to the slide. Settings that are high risk in transmission in Grey Bruce in the past few weeks have been private settings. It's household, it's friends. That's where the transmission is happening with around 80% or the majority of cases. Settings that are related to schools, workplace, grocery stores, all these settings that are regulated are safe. The number of cases that acquired the disease in a workplace is close to zero in Grey Bruce. And that is to say, our workplace is safer than our homes, including any workplace in Grey Bruce that is following the regulations. So one point there of success is the fact that we have our schools open for 3 months right now with zero transmission within the facility and childcare as well. And that is related to two main fronts. One of them are the public health measures that are implemented, whether it's screening of kids before going to school, physical distancing, hand washing, the 3 W's. And that's a joint effort with the school officials. That's first front, ensuring that safety. The second one is public health response whenever a case is identified to be potentially shedding the virus in the school. So if you put it together, there is a really good message that we've been putting it out to the public that this is manageable, quite manageable, even when we're dealing with subpopulation of younger kids who don't have the same reliability as adults. And that really emphasizes that those 3 W's and the measures that we have would be successful in managing the outbreak without the need to go into restrictions. Communication and these measures hopefully will carry us through until we get the vaccine. And that's the last point I wanted to mention. With the 95% efficacy, this is practically very good news. Because if it was 70%, it means we need to vaccinate 100% of the population, and we know that's not practical. With 95%, to completely have herd immunity of 70%, we need 80%, and it is quite doable in Grey Bruce. The second point about the pandemic, we have distribution plan in place since August and September. There are certain logistics recently that surfaced with the need for a freezer of minus 70. However, local solutions could take care of that. And shout out to Chapman's Ice Cream. They were proactive when we reached out to them to ask them if they can build such a freezer. They have already been looking into it. Communication went to the ministry to explore if we can pilot distribution of the vaccine in Grey Bruce, since we are able in the imminent future to have all the ingredients to pilot. And those later today we have a meeting with the ministry. It was scheduled for yesterday, however, delayed till tomorrow or today. There is a milestone before the herd immunity that can happen as early as April or June, depending on the distribution or the supply of the vaccine. And that could be could have many challenges, whether international supply or within the province allocation. Nevertheless, if everything goes well, we can reach the herd immunity, I believe, in April, or in worst case scenario, June. Sorry, I should quantify it there. If everything is in place, we could reach it in April to June. There is an earlier milestone than the herd immunity, which is vaccinating high-risk groups, older adults, people with heart and lung disease. And the second group is healthcare providers. Mr. Chair and board, these two groups are the source of danger for the pandemic, because any one of them, if affected by the pandemic, it could stall the healthcare system, whether by physicians and nurses being in isolation or healthcare workers being in isolation, or by the number of patients, high-risk groups, overwhelming the capacity. And if we vaccinate these two groups, by definition, we really averted the worst of the pandemic, and it becomes quite manageable without expectation of people going to the hospital if they got infected. Our initial assessment, that number could be around 20, 30,000. And we know practically we can vaccinate that group within realistically 2 months when we have the vaccine. That's my final point there. If we look back over the past 2 months, we vaccinated more than that number with the flu vaccine. So it's quite doable with the local capacity to have a milestone maybe in February or March, if everything goes according to plan and the supply is there. Again, there are many ifs there. So back to that slide, that really helps us, one set of tools to observe and have an early indicator. This data is not descriptive data. Usually whatever cases happen or tests happen, it's already in the past, and we receive it and we look at it and we infer from it. This data is surveillance, so it would give us close to real time what's going on. And if you look at, for example, the online self-assessment that's to the right in the middle, this is the assessment, provincial assessment, that the public fills on a daily basis before they go to work or school, or if they have some symptom and they wanted to see if they should be tested or not. We receive this data, our team looks at it and analyzes it and puts it in a graph like this. This could be an early indicator of anxiety in the public. Might not really reflect what's going on with the disease, rather the anxiety in the public, and it would give us some indication. These graphs are sensitive, not specific. In other words, they might spike a few times for nothing. However, if we follow them, we can see something happen before it actually translates in cases in 2 weeks after. The other graph, school and childcare absenteeism, that's top left. Those data sets come from the schools and the childcare filled on daily basis or collected and analyzed on weekly basis. And we can see certain changes in it. The one November 11th, that's Remembrance Day, you can see that attendance to school for high school kids went up. Basically, almost everybody went back to school, which is anomaly. You look closer to it, you can infer from it different things. Maybe when parents are at home, the high school kid has no way to stay at home, so they go to school because they probably were not sick to start with. We can see in these signals certain things that could be helpful in predicting what we need to do. The final point there on that graph, the childcare risk status today to the right top, it's the percentage of childcare that might have low, medium, or high risk, and that's different metrics that go into this, whether the number of people who are absent, number of people who might have symptoms, the type of symptoms, the area around the childcare, whether it's the school that's associated with it or the community, and if there is green, yellow, or red. So we can tailor our attention and deploy staff or communicate with these facilities based on this information. So that's brings to the end of this update, Mr. Chair. Open to any questions.
Thanks, Doctor. Any questions or comments? I found that very interesting.
Mr. Chairman, if it's okay, I'll ask my question now that I talked about earlier in the meeting. Just looking for a comment from Dr. Era. It's been a long time since I took chemistry, and I was curious with the one vaccine that's proposed to keep it at that temperature, that -70. Would it be the components of the vaccine that make it that it has to be held at that temperature versus the other vaccines that look like they'll become available that don't need to be kept at that cold of a temperature? Just wondered if you know or would like to comment on that.
Certainly, through you, Mr. Chair, the stability of the vaccine is usually depends on different factors. Temperature is one of them. One of these vaccines requires 70% for the molecule to stay stable. The other one, Moderna, I believe it's 20. I said 70%, -70 Celsius. And Moderna is -20 Celsius, which is closer to the other vaccines. However, when you put them back to regular fridge temperature, they will stay stable for around 5 days for one and 7 days for the other. And that window of time is sufficient to distribute it to a healthcare provider and leave it in their fridges for a couple of days until they use it. There are challenges with logistics, however, it's quite doable. So the back to the question, a low temperature is required to keep the molecule stable. And again, I'm not the expert in that molecular structure characteristics, but it is exactly that point that you mentioned to make it stable.
Thank you.
Question, Mr. Chair.
Sure.
Just a comment first to board member Barfoot's comment there that he's been a long time since he's done chemistry. I'm pretty sure he's still married, so he's very much involved in chemistry, I'm sure. Anyway, that notwithstanding, the question I had for Dr. Era was his timelines for potentially vaccinating the number of people that we need to vaccinate, the high risk people. There was a number of breaks in the supply of the regular flu vaccine to various outlets. If those breaks in the supply were taken out of the system, I would suggest we could vaccinate a lot more people in a shorter period of time. Would that be a fair assessment, Doctor?
That's a fair statement, correct.
Excellent. Thank you.
Mr. Chair, if I may elaborate on that, there are different barriers to any operation. In this case, some of them are communication related. How much communication can we do to provide to the public information about the safety portfolio of the vaccine when those statements from NACI? NACI is the National Advisory for Immunization Committee. That they are usually the body that puts out information and statement on the efficacy and the safety. So communication to the public, that's something our team is already working on to provide that information and ensure that the public would see the appropriate safety when we have the information. Distribution is rightly pointed out, if it is interrupted, that would be an issue. If we are an early adopter, we might be able to position ourselves for competitive advantage that other areas might not be ready. So we might have some advantage there with the amount of vaccine available for us to distribute. National distribution, that's above our control, definitely. A provincial distribution, we might advocate. However, it's outside of our control. Technical logistics issues, again, to have distribution system, whether it's the mechanics of it to get our staff to deliver the vaccine to healthcare providers or set up mass immunization clinics by our staff or in collaboration with healthcare providers. And that's, introduced other, I call it barrier, but it's an opportunity. Any one of these barriers are opportunity to communicate with healthcare providers early on. And I've been doing this for 2 weeks to see who would be willing to collaborate on mass immunization clinics, similar to the one in the peninsula, where the family health team immunized 1,000 persons there in one clinic over a few days. So again, there are multiple barriers. However, all of them are opportunities, and I'm confident locally we have the commitment from all partners to move it as fast as we can.
Mr. Chairman, Buck here.
Go ahead, Buck.
Thank you. Dr. Era, you mentioned in terms of priorities for the vaccination, you talked about seniors and healthcare providers. You didn't include in that group first responders. Why was that? I would think that first responders would be in that priority group, would they not?
Thank you. And they would be definitely. Healthcare workers usually include first responders for EMS. However, they might include as well police and fire if the need be. Usually these decisions about priority come again from NACI, from national level, and the decisions provincially to adopt them or modify them. So it's an educated guess that those would be the priority. If you look specifically about first responders, fire and police, if they are affected and in isolation, the hospital system is not going to stall. The system, the service they provide might be affected, but in general, the death and suffering would come from the hospital system. So I didn't include them, fire and police. I would include the ambulance in my educated guess. Again, that all could be changed when we see the direction from the ministry.
Thank you.
I thought maybe, Buck, you were going to ask for lawyers and politicians.
Well,
lawyers are always included. We draft the legislation after all, right?
And through you, Mr. Chair, there are other categories, whether it's First Nation and other high-risk groups. I wouldn't be able to go in details just because we didn't see the priority list yet. We are looking at the priority list that was generated in SARS. That will be probably a good indication of the list that's going to be produced for COVID.
Okay, thank you. Is there any other comments before we...
Mitch, I have a question.
Go ahead, Chris.
Dr. Era, based on the data on your chart there, what would be the next threshold for us to move up to the orange level?
So the decision to move from one level, from one color to another color, is really looking at the holistic picture of the indicators, and some of these are related to that set of indicators and some of them are not. Plus those set of indicators that are used by the ministry, they would look at them, then we provide our local assessment of the trends and how they are moving. So the decision is really not a certain threshold on one metric, rather, rightly so, the complex picture that we look at locally and with a provincial lens as well.
Okay. I just had, given the huge size of our area, the map there does show the that in the south, Grey and Bruce, you do have the justification to go to the next level, but Owen Sound and Georgian Bluffs could be in the green level. So how would you balance that off when you're making a decision? I guess from green to yellow wasn't much difference, but if we were to go from put the whole area in lockdown when, say, Owen Sound had very low numbers, that would cause a lot of consternation.
I agree. And when you see the high numbers, for example, in a certain town, 10 cases in one day, then you look closer, it could be 2 families and 1 sporadic case. So the risk is really not 10 individual incidents, rather 3. Each family is 1 incidence. Then you look at the different setting. For example, one of the health units 4 weeks ago had 55 cases on top what their baseline is in one day. And you look closer, it was 1 facility, 1 long-term care, 55 cases in one day. That doesn't really change the risk in the rest of that health unit significantly. And those things are factored in that decision. So the fact that some parts of Grey Bruce might have higher incidence at this point really is not significantly different from other areas at this point. So all of them are rightly so at yellow at this point.
So overall, looking at this data, even though there was a little bit of a shock for people moving up a level last week, we seem to be stable. So it's looking, as you say, manageable.
I would agree with that. I'm cautiously optimistic that we are able to, or we are on a right trajectory to control it just with communication without further restriction.
Okay, thank you. Okay, so if there's nothing else, we will move on to the opioid situation for Grey Bruce. And Doctor, I think you wanted to add this as a standing item on our monthly board meetings.
Correct. Thank you, Mr. Chair. I do believe the opioid crisis is important, and there are a few champions of this crisis, or champions to combat this crisis, that warrants having this item on our agenda on monthly basis. At the end of the year, if we have 0 deaths related to COVID and 13 or 15 deaths related to opioid, it wouldn't be the right balance without tackling both. I realize that COVID is an emergency that we're all involved in. Opioid, we have been involved in. However, it's a bit more complex of an issue. And my update here, Mr. Chair, has 3 quick points. One of them is the multifactorial and underlying principles to the issue itself, which requires approaches, multiple agencies and partners approaching it. It's related to housing, it's related to poverty, it's related to many issues. So in general, in this update about harm reduction, which is one approach to tackle this issue, the health unit has partnered with the Grey and Bruce County Housing, with other partners like the Canadian Mental Health Association, to offer harm reduction services twice a month in Wyerton. There is addiction treatment clinic in Saugeen Shore, and the Hope Grey Bruce as well as a partner. There are certain new partners to help in education and the distribution of naloxone kits, whether it's family health teams or police services, emergency medical services, and other partners. And it's worth mentioning in the last paragraph, you'd see there that we had to move certain staff from the harm reduction team to support with COVID response. However, the core of the program, which is naloxone distribution and needle exchange program, have been still operating as to support the community. And probably when we publish the minutes or publish the document, it shouldn't be my signature there. It's a harm reduction team that prepared this report. Just a point of clarity there. And I will stop there, Mr. Chair, for any questions.
Thanks, Doctor. Any questions or comments?
I have one, Mr. Chair. Dr. Do you know what the death number is at this point in 2020 for opioid?
So the team pointed out that anecdotally it's 13 deaths this year. These numbers usually come later after the year end from the coroner statistics. There's a lot of stigma still around it to actually know ahead of time, but the numbers they pointed out at this point is 13 deaths in the past 8 months. However, you would see, for example, July 21st and July 31st, there were opiate alerts where 6 people were overdosed and 1 was fatal, unfortunately.
Right. Okay, thank you.
Any other comments on that report? Okay, hearing none, we will move on to public health modernization, our monthly update.
Mr. Chair, that item has a very short update. There hasn't been any official announcement or direction from the ministry to move on the consultation for public health, and we still stand by on that file.
Okay, thank you. Any questions or comments? Okay, hearing none, do I have a mover and seconder to endorse Dr. Ayer's report?
Milne.
Edie.
Brian and Ann. Any further discussions? Anyone opposed? Hearing none, I will consider that carried. Thank you. Okay, next up we have corporate services, the financial report.
Yes, thank you, Mr. Chair. I presented the September financials along with a memo on those. Just a very quick overview is we are beginning to spend as we had anticipated as our hiring has ramped up. You can see the beginning of the build of hours. We expect that trend to continue for the rest of this year, and that's not unexpected.
Sorry, would you be able to put the graph on the screen, Aaron, if it's not too much trouble?
Yep. Thanks, Aaron. So you can see the beginning of the building of hours, and that's translating into dollars. And we do expect that as our hiring does continue. We have to date hired 51 new people for the year. That's a gross number, not a net. We've had a few retirements. However, the impact is, I think, clear. That we will continue to have some greater resources being applied to our response to the pandemic. Into my report. Didn't realize that Chair was gone. Sorry, Mr. Chair, I had finished giving a brief update on the COVID versus hours commentary that was embedded within the memo on the financial. So it's the end of my report on the financial piece, and there's also 2 memos that deal with purchasing of equipment for the dental. We've run into an administrative, but yet a barrier that we would like to step by to ensure that we can do some purchasing by the end of the year. We asked for tenders. We received responses that we could not accept for various administrative reasons. So we moved towards a quotation process, and we followed asked for 3 quotes. We provided the information and the selection that we would like to move forward on. This is outside of our policy process, and hence the reason why it comes to the board.
Okay, thank you. So I think we'll take a couple or three motions. The first one for the financial report, September 20th, September 2020. Do I have a mover and seconder for that report?
O'Leary.
Sue.
Okay, any further discussions? Anyone opposed to that? Hearing none, that's carried. So the 2 dental purchases, we should do these separately. So a mover and seconder for the first report.
Edie.
Buck.
Okay, thank you. Any further discussions? Hearing none, is anyone opposed? Hearing none, I will consider that carried. The next report, mover and seconder,
Millen.
Brian? Seconder?
Sue.
Sue, thank you. Any further discussions? Is anyone opposed? Hearing none, I will consider that carried. Thank you.
Mr. Chair,
Yes, sir.
just a, a question perhaps to Matt or anyone for that matter. $25,000 seems to be a rather low number to go to tender. Is there any suggestion from Matt that maybe we should reconsider that number and push it up a bit?
Through you, Mr. Chair, thank you for the question. And I think that that observation is completely valid. I do know that there is some history behind some of these numbers. I'm not completely aware of all of it, but I would like to take that back and think about it and ask some further questions and report back to the board.
That would be excellent. I am aware of some of the history, why those numbers are there, and I'm not going to share them right now. But anyway, thank you.
Okay, thank you. Okay, moving on to 10, item 10.1, all staff holiday lunch options. Dr. Era.
Thank you, Mr. Chair. So a quick item there. Due to COVID, we are suggesting or thinking that it would be best to have virtual lunch and maybe provide our staff with the gift card for a meal or for anything that they wish, instead of having the gathering that we usually have in the health unit with the board members due to COVID. And I wonder if the board would be would have any thoughts about that or direction for different from this.
Okay, thank you, Doctor. Any comments from the board?
Question for Matt: would those gift cards be taxable?
Yeah, the unfortunate answer is yes.
Yeah, I was afraid of that. There's no way around that, right?
There is. It's considered to be cash or cash-like.
Sure.
That becomes the piece. So if we were providing a meal, that's there's a $25 limit to the meal itself, and if it's not breached, then it's not taxable. But if it's in cash or like cash, it becomes completely taxable.
Yep, I suspected that. Thank you.
Other comments?
I just had a question. So say you wanted to just donate your share to a charitable organization, then would it be taxable? Like you'd
yeah, so there's two different transactions there. There's the one that from the health unit to the person, that's taxable. And then if the person decides to donate it, then they fall back through the charitable donation process on their own personal tax return.
Which isn't as robust.
Right.
Okay.
There are two different rates. It would not be a wash.
So I'm not hearing anyone opposed. Dr. Era, did you have an upset limit to the gift cards?
I will defer the question to Matt. We had looked at the previous cost is somewhere in the nature of about $15 a person to $20 a person for food. The concept was to, instead of spending it on a meal, it was to actually provide the gift card. But with turning this into a taxable expense, I think there's also the room for thinking about other ways to show our gratitude to our staff. Just open that further purview up. If it's not just money, it might be something else. Don't have an idea what that something else is at the moment, to be frank, but I think we would look to do that.
Okay.
And to consider.
All right. Mover and seconder to get that on the floor for approval.
Edie.
Seconder.
Sue.
Sue, thank you, Sue. Any further discussions?
What is the motion we're being asked to approve right now? Sorry.
To provide a gift cards in lieu of lunch being served, as we always do.
Right. Okay. Thank you.
Or I thought other ideas as well, like to give staff authority if there's something better than giving a taxable gift. Right? Or was that just that's not included in this motion?
No, I think it's just for the lunch.
Okay.
Mr. Chairman, just point of clarification. Could it be, Matt, like to a grocery store, or what else were you thinking?
This issue of taxation came up fairly late in the process. So any gift card to anywhere is considered to be that cash or taxable piece. The ideas have not completely percolated through, so we'll be able to do that, I think, in fairly short order. I think at this point, we're simply thinking about the financial. If we do move forward with something along those lines, then that would clearly be still at the board's discretion to authorize.
Is that clear?
Yeah, it's clear to me, and I certainly support it. One thing I would ask Matt to consider is trying to provide gift cards, if you go that route, to local businesses as opposed to multinationals.
So noted. Thank you.
Okay, further discussions? Hearing none, is anyone opposed? Hearing none, I will consider that carried. Thank you. Okay, item 10.2, the Grey Bruce Ontario Health Team application submission.
So, Mr. Chair, this is just to follow up on previous direction from the board to respond to one of the community boards or community, the board for one of the health organizations in Grey Bruce to echo their correspondence or call to ensure the importance of having governance at the planning committee or in the Grey Bruce Ontario Health Team. So that letter went out, and it has sent the right message, resonated with partners, and I do believe some of the board members wanted to comment on the item as well.
Sue.
Mr. Chair, I would just like to share with the board that I did attend a couple of those meetings, and the intention of this group is to have the health team planning committee include a governance structure in this application for the Ontario Health Team for Grey Bruce. And to date, there's been no success to have that included in the application. And the group just asked, when I did attend, that this be brought to our respective boards. So, but I think we're all aware that that is not in the application. Dana Howes and Jerry Glover have been out giving presentations, and each presentation has shown there's been a specific mention of the governance structure, which now is called decision-making structure. So their answer is that it will be there in the future, but not in the initial application, at least at this time. Thank you.
Thank you, Sue. And that was something I brought up to the presentation that we had at Bruce County Council as well, that governance must be part of this application. So other comments?
Mr. Chair, sorry, go ahead.
Oh, I was just wondering if that criteria was left out of the general criteria for submitting applications, or are other applications for Ontario Health Teams including governance structure? Does anybody know that?
Mr. Chair, from discussion at that group with an expert sitting at that table providing that information, one of the successful applications is for Ontario Health Team is in Guelph, and they included governance ahead of time, rightly so. That's a better practice. The direction from the ministry on the build of these teams is to include governance. However, some areas did not include governance, and their application were submitted. When I asked specifically at the planning committee, what would happen if one or few boards don't sign up on the application because governance is not there? The answer was not clear. However, it insinuated that the application would go through with whomever signed, then down the road that would happen. But back to the question to Mayor Edie, the direction from the ministry is to include governance. It is named in the criteria there.
Good to know.
Yep, go ahead.
So I was just wondering, should we have any, a follow-up letter regarding that? And maybe at the county level as well, that we would prefer the application does include some governance suggestions at least.
We could give direction here and at the boards.
Mr. Chair, if I may, so the board gave direction to send a letter to raise awareness about the issue before we encountered this governance issue. And that letter was ready. However, we put it on hold for a few days until we have this meeting to get that direction to include governance in it. So it will be one communication going out.
So my only concern is that this late date. Oh, sorry. I just is seeing that their application has to go in so shortly. Is there time to give a thorough thought and gather the information necessary for governance? I think it should have been part of it. Definitely. I think that's very important. But that's the other side now with the timelines. So I'd like Dr. Era's opinion or somebody's opinion on that.
Mr. Chair, so the advocacy letter is ready, and the wording to include governance is could be just one component emphasized there and could go out. The group that the vice chair and myself attended is quite active to ensure communication to different partners about the importance of this issue. So I believe there is enough level of advocacy in both initiatives to address this issue.
Other comments? Okay, hearing none. So you're good to go then, Dr. Era?
Yes, Mr. Chair.
Okay, mover and seconder to receive that report. Edie and Sue, any further discussions? Hearing none. Anyone opposed? Okay, I will consider that carried. Thank you. Okay, next up, we're going into closed session. So I need a mover and seconder to go into close.
O'Leary.
Seconder.
Buck.
Buck. Anyone opposed in going into closed? Hearing none, I will consider that carried. So we are now going in closed. One item in closed that we're bringing out into open. Aaron, would you read that, please?
I can read it. This is just draft at this point. So I don't have a mover and a seconder yet, but
I have a mover and seconder to get it on.
I'll move it.
Brian. Seconder. Buck.
O'Leary.
Okay, Aaron.
Okay, so moved by Brian Milne, seconded by Brian O'Leary, that the Board of Health for the Gravers Health Unit ratify the ONA contract as presented in the memorandum of understanding.
Correct.
Yes.
Okay, is there any further discussions? Hearing none, is anyone opposed? Hearing none, I will consider that carried. Okay, thank you, folks. Last item of business today is the motion to adjourn. Moved by Buck, seconded by Sue. We're now adjourned. Thank you, folks, and please stay safe.
Thank you, Mr. Chair. Take care,
Good
everyone.
weekend, everyone.
Yep.
Bye.
Bye.
Hi.
Bye, everybody.